Hello, I'm Dr. Jonathan Silverberg. I'm a professor of dermatology and director of clinical research and patch testing at the George Washington University School of Medicine and Health Sciences in Washington, D.C. With the recent development of different treat-to-target guidelines or consensus statements in atopic dermatitis, I think it's important to think about how to use those. They often are separate from treatment guidelines per se, or from society guidelines like from the ETFAD or from the American Academy of Dermatology, because those guidelines typically will just give you recommendations for treatment options you can use. But when then trying to understand, well, what should my treatment targets be? What should the goals be? There, we have less guidance from the guidelines. So the treat-to-target approach is something that has been around for quite some time. It's been used in other immune-mediated disorders such as rheumatoid arthritis and other disorders, where the idea is, rather than just having this sort of fuzzy clinical gestalt assessment of how the patient is doing, to try to standardize the assessment with feasible and valid tools that you can use in clinical practice, but importantly, to set realistic expectations or realistic goals for what can be achieved with a therapy in that disease. And so typically the way the treat-to-target guidelines work is they'll set earlier, more modest targets where we understand it can take time to really get a full clearance, a full depth of clearance. But early on, we want to see at least some good clinical improvement. So there, for example, if we chose itch as a domain to think about, maybe a modest endpoint would be a 4-point reduction in itch. And that might be achieved depending on which of the treat-to-target guidelines you look at, maybe within the first 1 to 3 months. But over time and with good control, we can definitely aim higher than that. And for many, we can really try to push the bar and aim to be itch-free, an NRS itch of 0 or 1. Well, that may not happen instantly. That may not happen in the first month. But already by month 6, some of the treat-to-target guidelines have even suggested as early as month 3, given the availability of new potent therapies. But we want to aim for a more robust endpoint a little later on. And of course, each domain and each outcome measure is going to have its different thresholds, and I would encourage you to look at the literature to get an insight into that. But I think the treat-to-target approach is very important to incorporate into your treatment framework. It's not necessarily meant to be rigid either, because for some patients that are really refractory, no matter what you throw at them, you may not be able to get them fully itch-free. But it really encourages you to give you some pseudo-objective or standardized way of thinking about what to expect for therapies, how to counsel patients about what they should expect for therapies, and when you should start thinking about either stepping up or switching therapies.